Cystotomy, for simple excision of vesical neck. The physician accesses the bladder neck and removes diseased or enlarged bladder neck tissue. The bladder is sutured and the abdominal wall is closed. Cystotomy, for excision of bladder diverticulum, single or multiple. The physician removes a diverticulum, a herniated defect of the bladder. The physician makes an incision in the bladder and may insert a ureteral stent if the diverticulum is close to the ureter. After dissecting the diverticulum from surrounding tissues and arteries, the physician excises the defective tissue and closes the remaining musculature and mucosa with absorbable sutures. This process may be repeated in other diverticula. Cystotomy, for excision of bladder tumor. The bladder is incised, cystotomy. After removing the tumor and surrounding diseased vesical tissue, the physician inserts a drain tube and performs a layered closure. Cystotomy for excision, incision, or repair of ureterocele. The physician makes an incision in the bladder to remove or repair a saccular dilation of the ureteral end, ureterocele, that protrudes into the bladder. The physician incises the bladder, cystotomy, and excises or fulgurates the ureterocele. After examining the ureter for other defects, the physician sutures the bladder incision and inserts a ureteral catheter. The physician inserts a drain tube and performs a layered closure. Cystotomy or cystostomy, with fulguration and/or insertion of radioactive material. With cryosurgical destruction of intravesical lesion. The physician makes an incision, cystotomy, or creates an opening, cystostomy, into the bladder to destroy abnormal tissue. Report 51020 if the physician uses electric current, fulguration, or, usually with the aid of a radiation oncologist, inserts radioactive material to destroy a lesion on the bladder. Report 51030 if the physician uses cryosurgery to destroy the lesion. Cystostomy, cystotomy with drainage. The physician creates an opening into the bladder, cystostomy, through an incision in the bladder, cystotomy. The physician makes a small incision and inserts a catheter, cystostomy tube, into the bladder, passing the tube through a stab incision in the skin of the abdomen. After closing the cystotomy, the physician may insert a drain tube, bringing it out through a separate stab incision, and performs a layered closure with absorbable sutures. Cystotomy, with insertion of ureteral catheter or stent. The physician makes an incision in the bladder to insert a catheter or slender tube, stent, into the ureter. The physician incises the bladder, cystotomy, and inserts a stent or catheter in the ureter. Insertion of a ureteral catheter requires that the physician bring the tube end out through the urethra or bladder incision. The physician inserts a drain tube and performs a layered closure. Cystolithotomy, cystotomy with removal of calculus, without vesical neck resection. The physician makes an incision in the bladder to remove a calculus. The physician performs a cystotomy, isolates the calculus, and removes it. The bladder neck is not excised. After examining the bladder for other defects, the physician sutures the incision and performs a layered closure using absorbable sutures, inserting a drain tube through a stab incision in the skin. Cystotomy, with calculus basket extraction and/or ultrasonic or electrohydraulic fragmentation of ureteral calculus. The physician makes an incision in the bladder and inserts an instrument in the ureter to remove or destroy the calculus. After isolating the calculus, the physician makes an incision in the bladder, cystotomy. The physician inserts an instrument, e.g., a stone basket, through the bladder incision into the ureter to remove or destroy a ureteral calculus. After examining the ureter for other defects, the physician inserts a ureteral catheter and sutures the incision. The physician inserts a drain tube and performs a layered closure. Cutaneous vesicostomy. The physician connects the bladder to the skin, cutaneous vesicostomy, for direct urinary drainage. The Bloxam technique is usually performed on newborns. To access the bladder, the physician makes a suprapubic incision in the abdomen and cuts the corresponding muscles, fat, and fibrous membranes, fascia. After securing the bladder dome to the rectus fascia, the physician incises the bladder to create an opening that is sutured to a small incision in the skin. To support the opening during healing, the physician inserts a catheter or stent into the bladder. The physician inserts a drain tube and performs a layered closure. In adults, the Lapides technique passes a flap of bladder beneath the skin to replace a retracted section of abdominal skin. The abdominal skin is passed below the abdominal surface and sutured to the opening in the bladder, making a long-term tubular passage for urine. A catheter is placed through the stoma for 2 or 3 days. Cutaneous appendicovesicostomy. The physician connects a segment of cecum colon, vermiform appendix, to the bladder to directly divert urine flow through an opening in the skin, cutaneous appendicovesicostomy. To access the bladder and cecum colon, the physician makes a midline incision in the skin of the abdomen and cuts the corresponding muscles, fat, and fibrous membranes, fascia. After dissecting vermiform appendix, the physician sutures the colon to restore bowel continuity. The physician makes an incision in the bladder and surgically connects the proximal end of the vermiform appendix to the bladder. The physician brings the distal end of vermiform appendix through an incision in the skin of the abdomen to establish an opening, stoma, for direct emptying of urine. The physician inserts a drain tube and performs a layered closure.